Any process that injures the urethra or underlying corpus spongiosum that heals with scarring can cause urethral stricture. Causes include accidental trauma, iatrogenic trauma, and inflammatory conditions like balanitis xerotica obliterans or secondary to sexually transmitted diseases. Use of metallic stents is another minimally invasive modality for the treatment of urethral strictures. Memocath 044 is thermoexpandable titanium nickel alloy spiral developed for long-term urethral stenting. Contrary to other metallic stents, Memocath stents avoid secondary ingrowth of the connective tissue and does not get covered with urothelium. The Memocath continually expands the urethrotomized area until a new urothelial lining has been furnished from the proximal to the distal end of the stent. Evidence is emerging that the patency of the urethra is maintained even when the stent has been removed, after it has been left in situ for a period of 9 months to a year. Another major advantage is the ease with which the Memocath can be removed or replaced if necessary. Furthermore, this minimally invasive option makes it an attractive alternative to other major reconstructive procedures. This makes it an ideal treatment modality in patients with recurrent urethral stricture where open operation is not an option due to other comorbidity.
Today we will demonstrate the exchange of a urethral Memocath. This patient has extensive medical comorbidities and a long recurrent urethral stricture from the bulbourethra to the distal urethra. He also had a meatoplasty in the past. He had 2 urethral Memocaths placed adjacent to each other. However, the distal end of the distal Memocath was protruding and causing discomfort. The procedure is performed under spinal anesthesia with the patient in the lithotomy position. Flexible cystoscopy demonstrates the lack of uroepithelial ingrowth and the urethral patency. It is visible that proximal end of the 2 stents is at the bulbourethra. As the flexible cystoscope is removed, the junction between the 2 Memocath stents is visible. Cold saline is inserted via urethral catheter to soften the Memocath stent. The distal Memocath is removed with forceps. It uncoils completely and is removed atraumatically. Flexible cystoscopy demonstrates the healthy underlying dilated urethral epithelium. Image intensifier shows the remaining proximal Memocath. The flexible cystoscope is then marked with 2 clips to accurately measure the desired length of the distal Memocath. The clips mark the distance between the distal end of the proximal stent and the meatus. The correct size of Memocath 044 stent is then selected. The Memocath kit consists of the stent mounted on an introducer. The protective casing is removed with the scalpel provided, cutting the plastic bands away from the tip of the stent. The assembly can be mounted on a standard cystoscope, whereby the inner plastic core is gently pushed out. The cystoscope is secured at the correct length with the proximal tightening ring. In the correct position, the last 3 windings of the metal stent should just be visible. A feeding tube is attached to the 3-way tap at the side of the assembly. The stent is positioned under cystoscopic control. Fluoroscopy is used to confirm the position. 60-degree hot water is ready and aspirated into a 50 ml syringe. The hot water is injected through the feeding tube, and expansion of the end of the mammocath can be observed under fluoroscopy. The black ring is loosened and the cystoscope is removed against the transparent pusher sheet, which leaves the stent detached and in place. The new stent does not protrude from the meatus, and the fluoroscopy reveals correct positioning of both stents.
The MemoCut 051 is a thermo-expandable titanium nickel alloy spiral developed for long-term urethral stenting. It has a unique temperature-activated shape memory which makes it adapting itself to the host tissue. These properties make it easy to remove obstructed or migrated stents. MemoCut ureteric stents were first used in malignant strictures. They were well tolerated and they did not encrust. This encouraged us and others to use them in benign ureteric strictures in the long term. This avoids more invasive reconstructive surgery. Once deployed, the MemoCut keeps the stricture open. This avoids frequent stent changes and bladder irritation through the double gauge stents. In the following video, we will show you MemoCut insertion, MemoCut reposition, MemoCut removal, 1-year follow-up, and also briefly touch on its use in transplanted kidneys.
The MemoCut 051 kit contains 2 units, the stent itself mounted on an introducer and the dilator sheet with the matching guide wire. For stent insertion, a standard cystoscopy is performed, the ureteric orifice is identified, and a standard ureteric catheter is inserted into the distal ureter for retrograde ureterography. The stricture's location and length is visualized, and this picture is frozen on a second X-ray monitor. A guide wire is passed through the stricture and left in place. Sometimes an initial glide wire must be replaced by a stiffer wire over a standard ureteric catheter. 2 metallic needles are used to mark the proximal and the distal ends of the stricture. Whilst the needles are placed and fixed, the ureterogram remains on the second monitor to provide the landmarks. The distance between the 2 needles is measured with a sterile measuring tape. Stent length should exceed this distance. Care should be taken to flush and wet all equipment prior to use. The dilator sheet is then slid under fluoroscopic control into the ureter over the guide wire, previously left behind and positioned well above the proximal needle marker. The guide wire is removed and the blue inner catheter unlocked and removed. The position of the dilator sheet well above the proximal needle is confirmed again. The Mamocath 051 is mounted on an insertion system of tubes and a two-part protection cover with plastic straps around it. The cover is carefully cut with the blade provided away from the end of the stent. The stent is thus exposed. The stent is introduced through the dilator sheet and positioned at its tip above the proximal marker needle. 20 ml of 60 degrees hot water is ready to be aspirated. After removal of the innermost blue mandrel of the insertion system, the water is flushed through the end port until thermoextension of the proximal stent tip above the stricture can be observed. The most distal connector between the red and the blue ring is separated and the white inner tubing pulled out of the stent, which is thus detached from the insertion system. The final stent position is recorded with a plain X-ray. It may be necessary to adjust the stent position. As before, a contrast study confirms the patency of the migrated